Hi, everyone. My name is Allison Metz, and I'm a professor and director of implementation practice at the School of Social Work at the University of North Carolina at Chapel Hill. Today, I'm joined by J.D. Smith and Dr. Paris Davis, co-authors of the SSIR article, Community-Driven Health Solutions on Chicago's South Side. In this article, J.D. and Dr. Paris and their co-author, Abel Coe, describe their work partnering with the faith-based community on Chicago's South Side to implement a project focused on reducing hypertension among African Americans, with a focus on advancing equity and reducing disparities in health outcomes for community members. JD and Dr. Paris, I'd love for you to introduce yourselves, and would you also be able to share a little bit about your co-author, Abel Coe, who's not able to join us today?
Thanks, Allison. This is J.D. Smith. I'm an associate professor in the Department of Population Health Sciences at the University of Utah School of Medicine. And I'm also an adjunct associate professor at the Northwestern University's Feinberg School of Medicine. So I am the implementation scientist on this project, and I'm also a clinical psychologist, so lead a lot of the work around behavior change as well. Would like to introduce Abel Coe, who is our other multiple principal investigator on this project. Abel is a professor of medicine in general internal medicine at Northwestern University, and he also directs the Center for Health Information Partnerships, which is a center that's focused on leveraging EHR data and some really innovative informatics approaches that we're also applying in this project to help us better understand and also implement our blood pressure control intervention.
Thanks so much, JD. Dr. Paris?
Good morning. I am Dr. Paris Davis. I am an elder with Tridestone Full Gospel Baptist Church on the south side of Chicago. I am a part of the MPI team for this project, where I am the community engagement director. And so with community engagement, that goes along with what we've done for years with Pastors for PCOR, where I'm the executive director, and also TRCDO, where we serve about 20,000 people a year with various products and services to help sustain them through their daily living, like housing and food.
Thank you so much, Dr. Paris. Thanks to both of you for joining me for this discussion. The paper is incredible, and I know this is going to be a great conversation we have. Partnering with the community is one of the key tenets for equitable implementation, which you talk a lot about in the article. So Dr. Paris, I wondered if you could kick us off and tell us a bit more about how you laid the groundwork for the community to have a central role in identifying health priorities and selecting the intervention, and really the role of local churches specifically in this project.
We being Total Resource started back in 2005, I want to say, realizing that there was information that was not getting to the community, and the community was not having their voice heard in getting what they needed to do better. And when I say do better, live better, make wiser choices when it comes to their health, sustaining themselves in their day-to-day living. And so what we did from there is we allowed them to develop a voice that we could get at the research table, and then also have researchers come to us in the community and hear what we needed and not just come as an afterthought. And so what we were able to do there was to develop a curriculum with the voice of stakeholders in the community, saying, this is how you need to approach us and to keep us engaged. And so now we are almost 15 years later, and it has turned into an evidence-based model that PCOR uses. And the beauty of it is that it still continues to evolve as our communities evolve and situations that we need to address change.
It's fantastic. Thank you so much. So JD, Dr. Paris was just describing, the importance of engaging the community in having a voice and selecting the intervention. Can you tell us a bit more about the intervention that was selected for this project and how you approached adapting the intervention so that it would be relevant to the community and feasible for you to implement?
Yeah, I'd be happy to. So the intervention that we decided to start with is a multi-component intervention that was developed by Kaiser Permanente in California, and it is shortly just called the Kaiser Bundle to indicate the bundle of different intervention strategies that involve the EHR, single pill combination therapy for high blood pressure, different monitoring options, So the thing that we really did is Kaiser Permanente had, tested this, shown it was highly effective. They tried to move it to the community, and it was also effective in federally qualified health centers, but not nearly as effective as it was in its initial trials, which were, within Kaiser's kind of primary clinics. So it's really promising that they could translate it to some extent, and we are trying to, do kind of a similar thing on the south side of Chicago. The thing that makes it really unique is that we're both involving faith-based organizations and community health centers. One of the challenges of implementing in those community health centers was the burden of a multi-component intervention. And so our vision is to really work with the community members, work with the faith-based organizations to figure out which components of the Kaiser bundle could be done actually outside of the federally qualified health centers. And so that would actually be likely in some of the faith-based organizations, other community organizations that would also partner with us, as well as in people's homes. We know that people are getting much more used to healthcare and blood pressure monitoring and things like that actually happening in their homes. And so being really flexible about what the community wants to make this a really feasible implementation that has as few barriers as possible for community members.
Mm-hmm. Fantastic. Thank you so much. So Dr. Paris, hearing JD talk about the adaptations made to the implementation process so that it would be a good fit for the community, just would love to hear some of your comments on that and what were the benefits for the community from your perspective?
Well, from our perspective, as it is well known, Chicago is very diverse. You can cross the street and be in a totally different culture, a totally different set of living standards. And so the beauty of the adaptation is that we can tailor that to fit each community. And the way that you do that is through a drill down method where you go down into the community, you get the people to the table to find out how is the best way to get you the information and the supplies that you need to deal with tracking and controlling your blood pressure, to deal with tracking and controlling your dietary requirements. What meets you best? Because what we found is that what works in the suburbs of Chicago may not work on the south side of Chicago. And so having their voice and then also teaching our team how to be bilingual from the standpoint of talk the language of the researchers, take and translate it so that the community understands what they're being asked to do. Take the voice of the community back to the researchers and let them know, yeah, we hear what you're saying, but this is what we need for it to be successful in our communities. So that is the approach that has been working, is to teach each other how to communicate better other than just sitting at the table talking at one another and nothing getting done.
Right. Thank you so much for that description. So helpful. JD, I wondered if there were any other benefits for the community or your work that you just wanted to elaborate on based on some of what Dr. Parrish just shared with us.
Sure. Yeah, I'll speak kind of from the kind of healthcare delivery side of things and their interface with the community. So, much like Paris's example of walking across the street and being in a totally different neighborhood, two clinics that are really in similar locations could actually have really different patient populations, different cultures themselves. And so we're also taking a pretty parallel process to tailoring our implementation approach for each of the different practices that we're working with, so that it aligns with both their mission and priorities, but also, of course, those of the people that they serve. So that's kind of the parallel that we're trying to take with both our community engaged approach with potential patients and also the stakeholders and folks who are in the organizations that we're working with.
Great, great. We know that implementation takes time. That's one thing I think we all feel pretty sure about, is that it takes time. And this is a multi-year project, 7-year project, and there's still a lot to do. And I remember when you were starting to write the article, we were kind of commenting that there was still a lot that you were going to learn from this. So what have been some early successes for you? I know you just kind of described the community engagement approach, but what would you describe as some early successes, and how do you plan to manage ongoing adaptations as needed as you move through this long-term project? And either of you can jump in here.
I'm happy to take the first stab. So, some of I think honestly that this is a long-term project. It's a 7-year, but it's broken into 2 phases. So I'll talk about that in a second. I think one of our early successes really has been getting the right people in the room, so to speak. I mean, we've been mostly on Zoom since we're in the midst of the pandemic still, but really getting people from basically every important sector of healthcare, of faith-based organizations, community partners, patients, the research team, of course. You know, we have convened, everyone has kind of a shared idea and vision for what this can be. And that, you know, is really foundational for any kind of implementation project. And I think we've done a great job of getting those people to the table, getting their voices out there. So in terms of the kind of ongoing adaptation, as I mentioned, this is a two-phase project. So we have the luxury of in about 6 months, 7 months, we're going to start a pilot implementation, which is explicitly focused on adapting the intervention and figuring out how we're going to implement. And the kind of adaptations that occurred during that about year and a half process are going to carry us into a 4-year trial. The idea is, though, that, you know, the primary kind of most significant adaptations will have been made moving into the trial phase, but we're going to intentionally continue to adapt both to the changing landscape of healthcare delivery, of the communities that we're working with, and of course, potentially different health priorities. I think, you know, COVID has done a lot to really underscore issues in our healthcare system and in public health. And so I think we're going to have to continue to evolve. And my job is to try to have some kind of a scientific process behind that. You know, being this is a grant funded by the National Institutes of Health, and we would like to have something publishable and something that can be translated to other communities to benefit others' health outside of just the south side of Chicago, since many communities experience, you know, similar issues that we're hoping to address.
Thank you so much, JD. Dr. Paris, did you want to add anything about early successes or kind of where you see this going?
Absolutely. And to complement what JD has laid out, what we have begun to do in the community engagement component is that we have started to lay out common language. Again, communications is the key. And so in understanding how to bring people to the table, we have come up with a community-based mission statement so that when we're standing to engage the community, we're not trying to break down the big scientific message and mission of what we're trying to do, but we're putting it in layman's terms. The other thing is our whole team is being educated on the intervention package, the Kaiser bundle, and what it means and how it translates to what we want to get done. And so we're starting out by building the foundation for what our contribution is going to be to this project at the community level.
Fantastic. Okay, final question for you all as we close out this conversation. I'd love for you to reflect on your experiences so far, working with the community, selecting the intervention, adapting the intervention, implementing it. If you were mentoring another group that wanted to do something similar, what advice would you give them? And I wonder, Paris, if you wanted to kick us off with that advice.
Absolutely. Engage early. Engage early, and then also have the trusted voices at the table to start it. And by trusted voices, I mean where the relationships have been developed. Because at the bottom line, if you don't have relationship in the community, you are not going to be able to sustain yourself in whatever you're doing. So from the trusted voices, then the dedicated workers, the dedicated workers being those that the faith-based community trust, that they can go in and say, this is what we're working on right now, and we're not trying to start from scratch. Developing that trust component to get to the people that we need to get to. So those are the key things I would say for community engagement.
Fabulous. Trusting relationships and dedication and engaging early. So helpful. JD, any other thoughts on advice you would give to a group wanting to do something similar?
Yeah, I can't really add much to what Dr. Paris already eloquently said, except that potentially as a researcher and someone on the more academic side, I think you have to go into this with flexibility, open-mindedness, and be ready to listen to the community. That's, you know, but those two pieces coming together is really critical for any successes to happen.
Great, thank you. So incredible advice. So thank you both for your time. I really appreciated it, and And it's been an absolute pleasure talking with you guys. Thank you so much.
Thank
Thank you.
you.